Thank you very much. And then also sharing on our social media handle as I indicated earlier. So this webinar session is being organized by a group, the Africa Society of Quality, AFQA. This is a new group being championed by 4 organizations: the Africa Institute of Healthcare Quality, Safety and Accreditation, AFICSA, the Patient Safety Africa, led by Sonny, and then the Acquire in Kenya, Nairobi, and then COSASA, Jackie Stewart. So thank you all very much. This afternoon's session, we are looking at improving quality and patient safety in Africa, experiences and lessons from accredited healthcare facilities in Africa. So we have 3 organizations, the 3 organizations from Lagoon Hospitals in Nigeria, and then from South Africa, and then C&J in Ghana. Tabitha, forgive me for my inability to remember your organization, but I mean, as we start, we are giving all the panelists an opportunity to introduce themselves and then to share, and then briefly also introduce their organizations. So I have seen one of my colleagues from Acquire on. So maybe before the panel, I will ask Ruth Pell. Ruth Pell is with Acquire. So Ruth Pell, maybe a quick introduction from you and Acquire, and then I'll give the panelists the chance to do the self-introduction and we can start. So Ruth Pell, over.
Okay, good afternoon, Elom. Good afternoon, everybody. It's a pleasure to be with you this afternoon. Yes, Acquire is a part of this new informal organization trying to bring together people working around quality and working towards quality improvement here on the continent, to share lessons, to begin to, I hope, brainstorm on ideas and ways that we can learn from one another. And it's we are grateful to then begin to platform together the different things that we are doing. Acquire is, well, we are currently based in Nairobi, but we are working in several countries. And our interest is building capacity for quality improvement, work within the frontline healthcare system. We are grateful to be working with hospitals in Tanzania, in Cameroon, here in Kenya as well as Ethiopia. And we have a few quality improvement projects in a few hospitals in those countries. You are welcome to visit our website and reach out, and we are always looking for partners and looking for opportunities to learn and work together. Okay, I'm hoping your panel is ready, Elom.
Yes, yes, they are. Yes, yes, the panel is ready. So thank you very much, Ruth Bell. So please, over to you, panelists. So I think we will go from Nigeria, go to South Africa, and come to Ghana. So please, let's do it in that order. Some brief introductions about yourselves and your organizations. So Nigeria, South Africa, and Ghana. Please, over.
Well, thank you very much, Em. Thank you for putting this together. Incidentally, I need to be observant because somehow by some default, I've ended up as the co-host of the meeting also, which is fine.
Yes, so I have deliberately assigned all the panelists a co-host so that in case you would want to do any presentation, it is easy to do it without any prompts from my end. Yeah, so thank you.
Right. Yes, my name is Dr. Kunle Onokoya. By training, I am actually an orthopedic surgeon, but I'm now in charge of the quality improvement effort at the Lagoon. The Lagoon, we multi-specialty all the way from primary to tertiary care, healthcare services provider based in Lagos. We run 5 facilities in Lagos. I must say we are luckier than most because our founders were academics, and as such, they had the vision to put in place some quality improvement projects, right from quality assurance, quality improvement system right from the beginning. And we first became interested in JCI around about 2009. And we finally got our first accreditation in 2011. And I'm proud to say that as of March 2021, we got the 4th in the series of JCI certificates. I like to think that we are probably the only JCI, well, one of a couple of JCI certified hospitals south of Africa, southern Africa, well, south of the Sahara, with the exception of South Africa. But that is it by way of a brief intro. I'm sure we'll have the opportunities to say more in the course of the evening. Once again, Elom, thank you for putting this together.
Thank you. Thank you very much, Dr. Kunle. So we go to South Africa.
Good evening, Ilom, and good evening to everybody in the meeting this evening. My name is Tabitha Lolio. I'm a hospital general manager of Mediclinic Pietermaritzburg. My hospital is part of an international company, the Mediclinic International Group. We are based in Southern Africa, the UAE, as well as in Switzerland. So we are in Southern Africa, the Mediclinic Southern Africa Group. We're a group of at least 52 acute care facilities. Our hospital in Pietermaritzburg is based in KwaZulu-Natal, which is on the eastern side of South Africa, close to Durban. Some of you may know of Durban. We are a 222-bed facility, multidisciplinary. We've been proudly accredited with the CASASA accreditation team since December 2007. My personal background, I've been in hospital management for the last 8 years, and prior to that, I've been in administration for 17 years with Mediclinic. I have got a nursing training background. I'm registered as a professional nurse here in South Africa. Looking forward to this evening's panel discussion, and thank you again for the invitation.
Thank you very much, Tabitha. So we come to Ghana, CNJ.
All right, good afternoon, and thank you. It's a privilege to be here, and thank you, Alom and the team, for putting this together. My name is Hagar Hasford, Head of Operations and Quality Assurance of CNJ Medicare Hospital. CNJ Medicare Hospital is located in Accra. We have 2 hospitals, actually, one in the center of town, Tudu, and the second one, which is the headquarters, which also has the diagnostic center, is in Lashibi. We also have what we call the implant clinics, where we run clinics on the premises of our clients, particularly those in manufacturing who are minded in losing man hours due to ill health, and we manage the clinics for them on their premises. So we have 3 of these. CNJ has been in operation since 1993, fully owned Ghanaian company. In private practice, I believe that we are the first private facility with the largest collection of diagnostics. We've been conscious of quality, especially as we have expanded. I personally hold a degree in pharmacy, a master's degree in business administration, and a fellow of ISQA. And I have been in healthcare provision, management, financing for the past 23 years. I believe that there'll be opportunity to speak more.
Great, this is awesome. Thank you very much. Thank you very much. So let's continue. Just want to find out from any of you, any of you could start. Why did you take the decision to go for accreditation? What was the motivation? I don't know who wants to start. So maybe,
I'm happy.
yeah, okay.
I'll
So maybe South Africa starts and then we come to, yeah. So Tabitha, please go ahead. Yeah.
Thank you, Ilham. So the decision to go for accreditation didn't start at hospital level. It was a company decision made by Mediclinic Southern Africa. And the main reason the company went this route, and it was in the early 2000s, was actually to focus on the improvement of healthcare in the hospitals, and specifically focusing on quality and safety of the patients. It was quite a unique process to start with, in terms of, you know, your systems are already there, but now to actually formalize your processes with a view on quality improvement and quality improvement initiatives. So really the focus was on safe healthcare and improving the outcomes for our patients in all the facilities across South Africa.
Okay, wow, that's good to know. Dr. Kunle?
Yes, I think for us, it's an interesting beginning, really, because one thing we did notice in the mid-1980s is that there was a bit of a lottery with regards to patients' outcomes. And your outcomes, your complication rates, whether you survive or not, all seems to depend on which city you are and which hospital you go to. And there was really nothing to suggest standardization of care. And it seemed that even as we became worried about that, we discovered that if we are not careful, the same lottery seems to play out within our own system. And results could vary significantly by what the doctor's rota is like on the day you come to hospital, and the interest of the doctor, the qualifications of the doctor, the skills and experience. So there was a bit of a lottery that seemed to play out. And while that was largely external, we began to realize that even within our own systems, we did not standardize care as such. So that was a bit of a worry in the mid-80s. But I think what finally pushed us to start the quality journey was that we started having our bigger multinational clients who were being held to account by corporate HQ and saying, look, the quality of care we provide for our staff in Europe, in North America, we simply must provide our staff based in Nigeria the same quality of care. And to whatever standard we hold hospitals that look after our staff and their dependents in other parts of the world, we want to hold the hospitals that look after to the same standards. And I think we quickly realized that if we then didn't do anything, not only will these clients walk away, but it was also going to become something like an all or none for them. So I think it was both a business decision as well as realizing the fact that for our own care, we needed to standardize care pathways and so that we could ensure outcomes. That I think were the two main reasons, really. The rest were then, it was simply with time the correct thing to do.
Wow, thank you very much. I will come back to the word you used, the lottery. But let me go to Ghana and come back to you. Yes, Hagar.
Right. So I think that the C&J story is not too different. For us, one was in pursuit of our vision, which is to be the #1 hospital brand in Ghana and beyond. And when we are talking about brand, then we are talking about a certain standard and a certain predictability. And so basically for us, it was in pursuit of our vision and also growth and expansion. So as I said, C&J is a fully Ghanaian-owned company that started from a very small and humble beginning. And then in 2001 and 2012, we went through different phases of growth. And then the challenge associated with growth, variability, which we all know, and the need to have standardized processes and standardized care became a compelling one. And the need to have standard standardize processes so that we can improve clinical outcomes and quality of healthcare, and also to benchmark also with other facilities that were like we considered as our peers. So basically for C&J, that was the driver.
Wow, so thank you very much. Looks like there is some convergence as far as the motivation is concerned, quality, safety, and then the business aspect. But Dr. Kunle, please, if you could expand on what you mean by the lottery at the time, and then you could also tie that in with walking us through your journey. You are a JCI accredited facility, so you could tie both, look at both for us as far as your journey to accreditation was concerned and what you meant by the lottery as far as care is concerned. Over.
Well, in my country, I mean, the figures do, but we like to think that about 60 to 70% of healthcare is provided through the private sector, and the rest is provided by the public sector. There is the beginning of a health insurance in place, but essentially a lot of healthcare is provided out of pocket. Now that is one with regards to funding. And also is that really actually at the point of need, you really do not have much by way of information regarding the capacity and the ability of the healthcare providers that surround you. And what tends to happen is that at that point of need, you are then simply taken to either the nearest hospital, which might not necessarily be the best fit, considering what that specific need at the time is, or based on some experience of what the people who are at the point of care think. And then when you get there, because there is no standardization of care, what you experience in terms of input of care, in terms of care path, in terms of if it was surgery, in terms of how well it is done, in terms of the outcomes, is all dependent on who is there at the time you get there. This is what I mean. There is absolutely no standardization of that care. So if you get there and imagine that you get to a hospital and you meet a general purpose physician, a family physician, whose interest is in obstetrics and gynecology. Then if you are a woman who is bleeding at the time, then you are in good hands. But if you happen to have an abdominal surgical condition, then to be honest, you are probably not in the best place there is. And there is no system or structure in the place that guarantees the minimum level of safe care. That is a safe assessment, a safe diagnosis, and then some referral process. So a lot of your experience is totally outside your control. Even if you are fee paying, a lot of what the fee you pay buys you is totally outside your control. So it's a bit of a lottery. It's a bit of a lucky dip of who you meet and what you get. And the same thing plays out even within the hospital. Because if care pathways are not standardized and there are no protocols of care in place, then again, at the point of seeking care, it all then depends on who is on duty at the time, his level of seniority, his competence, and what have you. So what I meant by that lottery is that if one is not careful, the minute you walk in through the doors, your outcome is predetermined. And that could be positive, it could be otherwise, again, because there are no standards of care. And those were the things that we realized. And we felt that this cannot be right. I mean, this cannot be right. And I remember that in my early days as an orthopedic trainee, and I will be on call in a private hospital at the time, and somebody with vehicular trauma is brought in, somebody with something as simple as a shoulder dislocation will brought in. this is, I mean, at the risk of sounding immodest, this is probably something I could do with my closed. An hour after, I would have gone, and the person that is on duty is a pediatric registrar, and reducing a shoulder dislocation to him is as difficult as going to the moon. So those were the things that one thought really shouldn't be, and that was why we took the decision to go on the quality journey. Now, the first decision, the first question we had to answer was, what will it be? And we looked at JCI, we looked at CPHQ, we looked at, even we looked at ISO. And I must confess that what seemed to be easiest to acquire at the time was ISO. And we did start on that journey peripherally, but it quickly became clear that this is good for manufacturing, but it is not fit for purpose with regards to healthcare. So we then quickly narrowed it down for us to JCI and COSASA. Well, I know that there are some COSASA-minded people in the audience and on the panel, but that decision was then made at board level. What swung it in favor of JCI versus COSASA, I don't know. I have a feeling that, and this was 2009, 2010, it probably was felt that COSASA, that JCI was a stronger brand at the time. I mean, subsequent information have since shown us that, I mean, COSASA is just as strong. The important thing is really not the name. The important thing is the processes behind it. So we did a pre-JCI assessment in 2010, and I've still remember to this day the gentleman who came to do the pre-audit audit. He gathered all of us together, and the look on his face was something between don't bother or you guys are in for a lot of pain. And at the end, I then asked him and I said, look, sir, can you just give us a honest assessment? How prepared do you think we are? And he says, well, if I'm generous, you are 20%. If I'm realistic, you are something like between 9 and 12% prepared. And I think you can remember, you can just imagine the kind of night I had that day. Well, I think it then just showed us, well, one, the extent of what we needed to do, but also just kind of inspired us into we can do this moment. And JCI, as I'm sure COSASA did, provides a lot of support. And yes, there is a big financial hurdle to climb, but once you make that decision, it does provide a lot of hand-holding. We certainly required all that hand-holding. We didn't have policies in place. We had some clinical guidelines, maybe 5% of what we needed. So I must say, and this is really not to discourage anyone who is among the participants who wants to start that journey. It really was painful. 2010, 2011 was painful, but there are very few feelings that beat the evening when we did the first JCI audit, and we were told that indeed we have been accredited. I vaguely remember the man saying that we had some reference and we have a few bits and pieces to put in place. To me, those simply didn't matter. The fact that we have been accredited was worth it. And since then, we've done that journey 4 times, and none of them is easy, as I'm sure both Hagar and Tabitha will agree. In fact, it seems if each one is more difficult than the previous one, even though you know the things to do, but the auditors just simply hold you to higher standards. And what they'll probably let go in your, maybe in your first audit or second audit, they are just that more unwilling to. So I think that is the limit of that's our journey in a nutshell. The last one we did in March should have been in 2020 because JCI reaccredits you every 3 years. But because of COVID, we couldn't do in 2020. So we had to do a virtual survey in 2021. We thought that would be easy. It was far worse than having the human beings on ground, far worse, because the camera lenses will see things like that, and a human eye with 60-degree lens. And it will see, I could see Tabitha nodding her head, so I'll yield ground. I'm sure she too will have some things to say on that with regards to that. But really, that is it in a nutshell. Thank you.
Thank you very much. So let's go to Tabitha. How is the process like? If you could briefly walk us through the COSASA process.
Yeah, the experience very similar. My personal journey with COSASA actually started when I was still working as a nurse in a state facility back in the mid-1990s. And our management came to us and said, right, you need to write a policy for all the standard operating procedures that you do, and we need to put some governance and framework in place. And we all thought they'd gone mad because it literally felt like we were writing a policy for every little thing. Fast forward to my time now in Mediclinic, and although we had a lot of systems and policies in place in the company, there was no measuring against what's happening out in the industry, you know, and on an international basis. So when you first start with the COSASA process, it feels like you're climbing up this enormous mountain and you just don't even seem to get to the first base camp. But the journey was very much supported both from the company's perspective with Mediclinic, but also from the COSASA team. And we were given this governance framework that we could now actually work, you know, use for every single department in the hospital. And taking care of a patient is a holistic process. So it's not just about the clinical care, it's also about the admission process, the pharmacy side of things, the discharge process, and checking that all the people actually taking care of that patient is accredited and you know, valid healthcare workers working in the system. So it's quite an involved process. I think the biggest challenge for us, or what took the longest for us, it wasn't putting the policies in place. That, you know, that's quite simple because a lot of it is there already. It was the change management that actually comes with implementing policies in a hospital, or looking at KPIs and constantly improving. And exactly like my colleague was saying, you just think you actually reached it and you pass your first accreditation and the next one just gets harder. And why? Because quality should always be a driving factor in healthcare. We should never accept that what we did last year and that the fact that we passed an accreditation process was okay. It's continually improving on ourselves based on research that's happening on the international front. So that change management process really took quite some time to get going in the hospital. But I must say that this year we also had a virtual process, auditing process, and the actual process itself for the virtual auditing was a much tougher one. It's easier to do it in person. But the preparation to that audit was a lot easier because you knew what to expect. You know, you sort of conquered the mountain of putting all the policies and the procedures and the steps in place. That the change management, you can see now, these years later, it's embedded in the staff. The quality improvement is something that we do routinely now without actually thinking it's a policy or procedure, or it's an accreditation process. It is how we run our business. It is how we take care of our patients. And yeah, you know, the virtual audit takes away that interpersonal contact with the auditors and the assessors, because when they're here at hospital level, they're guiding you, they're looking at different things, that you're chatting to them, and you know, you're getting ideas on how you can improve further. We had virtual meetings, but it's a much tougher process, and yeah, I would prefer the in-person, but we were very successful and we had a good outcome this year from the accreditation. So yeah, definitely beneficial, but I think the biggest challenge is change, and nobody likes change. Everyone wants to do things the way they've done it historically, but change is absolutely necessary if we are going to continue to improve our standards and our quality.
I will come back and ask you of the change management process when you introduced your first policy and how that was introduced. But let me go to Hagar and see if there is another COSASA accredited facility. So Hagar, please, if you could, if walk us through briefly. I don't know whether the journey would be any different.
No, I mean, I was just saying to myself, it's both comforting and alarming to see that the challenges and the issues are basically the same. I think that for me, maybe my apt description will be like childbirth, the pain of labor, but you also know that at the end of it, there is a reward. And so it was quite a painful process, I must say. And it was the same for us. Our journey started in 2015 and then eventually accredited in 2018. I must say that at first evaluation, we didn't even get accredited, partially accredited, and we had to have a second focus survey to be accredited. The journey is training and the policies. I mean, I think those were quite a lot. Developing policies for every process, procedures. You know, we presented in all about 34 service elements for accreditation, and it was quite a lot. Along the journey, we had to do the self-evaluation. I think that our biggest challenge, and I think it's the same change management issue, was the culture shift. And also, I mean, embedding that mindset of this not being a project, but the way we want to work. This is the way we work. So it was quite a difficult process, but also at the end of the day, it was rewarding, knowing that, I mean, we really can do this and we did this. And I think that we are on our first run, and so we were due for re-accreditation and yeah, but then COVID and all that has delayed the process. But it's for us, aside even accreditation, we believe that this is even good for the practitioner, for the patient, for the institution. And so tough, but yes, we'll do it. And hearing from my colleagues that, you know, I mean, subsequent accreditation is even more difficult, like I said. I mean, so it's between alarming and yeah, but also comforting to know that the challenges are not peculiar to us.
Yeah, so let me ask this. Tabitha, you introduced the change management process. So how did you introduce your first policy, your first SOP? And how did you manage the anxiety and all the issues around the process and getting everybody to appreciate and understand that, hey, guys, colleagues, this is the way to go?
Yeah, thanks, Elam. I think the biggest change was not necessarily the implementation of policies, because healthcare is very much governed by policies and frameworks. I mean, from doctors, pharmacists, nurses, there's a governance framework already in place, you know, in the professions. I think the biggest change came in behavior of staff in terms of reporting. So if you can't measure outcomes and you don't know there's events happening in the hospital because people are too scared to report it, you can't change and you can't improve. So the culture had to change, where reporting of errors and adverse events in the facility were not seen as punitive, and it had to be seen as correcting behavior. So from a management perspective, it was making sure that we were keeping ourselves in check with the change, that actually what the outcome we are looking for is that people speak up when the system fails, that we report when there's an incident that happens in one of the wards with a patient, and we start talking about it and re-looking at our systems. And that falls in line with the whole accreditation process and your cycle of your PDSA or your quality improvement processes. So it's encouraging people to change their behavior by reporting incidents. And we initially struggled with that quite a lot because historically it was a punitive process. You know, you made a mistake, you got into trouble for that. And when the first incident happened and we worked through with the team that were involved, we could actually show them, well, this is why the incident happened. It wasn't because the person intentionally woke up in the morning to make a mistake. It was because these were the mitigating or aggravating factors in the unit at the time, and putting steps and systems in place as part of the quality process to actually change that. And changing people's minds by educating them what is the outcome that we actually want to achieve from making the culture one of more of a reporting culture, specifically in the hospital. Definitely had its benefits, and now we moved from reporting only adverse events or serious adverse events to reporting near misses, to say we picked this up before it became a problem, before there was any harm done to the patient. And I think that for me was probably the biggest challenge that we had in terms of change management, was changing the culture. And now the culture is very much a culture of patient safety in the hospital, and it becomes second nature. Once you get over those hurdles of why, and the fact that it's not punitive, it's about outcomes and creating a safe environment.
Wow. Thank you very much. I think I was, so please, our colleagues who are on, if you have any question you want to ask, please, you can type in the chat box, or you can indicate by raising your hand, and then I can give you the opportunity to do so. Thank you very much. So maybe we go to Lagoon. She talked about the issue of change. So I would like you to tie that in with how the accreditation process intersects with continuous quality improvement in your facility so far. Over.
Well, thanks, Ilom. In some very specific ways, to be honest, and some of them were in ways that were totally alien to medical practice at the time. And I'll give an example. During a mock audit, I mean, JCI is also good because they provide a mock audit, and the people who do the mock audit, there is a wall, a Chinese wall between them and those who come for the actual survey, so that the people who do the survey are not biased by what they've heard about your weak spots. And we were doing a mock audit, and the auditors had gone to the theater. And as they were going in, some general surgeon, one of the colorectal surgeons, was going in to do, I believe it was a colonoscopy. And the auditor turned to me and says, "Who is this gentleman?" I said, "Oh, he's one of our senior surgeons." He says, "If he decides to do a cesarean section, what stops him?" And very foolishly, I said, "Oh, he's a colorectal surgeon. He doesn't do cesarean sections." He says, "Yes, but the day he chooses to do one, what stops him?" And at that time, we had absolutely no concept. We had some credentialing in place, again, just by the very nature of the environment where we practice. So we had some credentialing in place, some primary source verification in place already. But we were not privileging people. I mean, you have a fellowship and you do the things you're qualified to do. And so you could imagine me then going to all these professors. We have about 34 full-time consultants on staff and about 36 visiting. And I then needed to go to each and every one of them to say, "Well, sorry, you do really we need to document what you do, what you are qualified to do. And you need to take this form and take, and show that you're a colorectal surgeon, you don't do tonsillectomies." And some of them were quite charitable and they saw the whole thing as a waste of time. But you could imagine, for some, they were outright hostile to it. So those were the kind of things that we had to go through with regard to the processes. Now, Tabitha had already spoken about the whole issue of documentation, and there is a whole load of it at the beginning. But what you have them in then do is to update them. But you still need to train on them. And that training has to be continuous because there is the continuous turnover of staff. And again, people forget, people see this as addition to their day job, the fact that they have to know about these policies, they have to practice these policies. So as an organization, you need to continually reinforce until it becomes a culture. But as the whole concept of quality care and certification and having international accreditation becomes better established across the continent. And I must say that as you succeed, one challenge you're going to pose for hospitals that are already accredited, and Higa and Tabitha be on the lookout, is that as more and more hospitals embark on the journey, the staff they need to start them off are those that come from hospitals that are accredited. So you suddenly discover that the staff that you have invested training and time and effort in become the prize acquisitions of hospitals that are about to start that journey. And it's just a fact of life. So you quickly realize that you have to make sure that the training involves all of your staff across board. Also is taking ownership of processes, taking ownership of procedures. The ICU staff just see themselves as, they ventilate, they put patient on ventilator. Yes, they are aware of all the ventilator-assisted pneumonia and the bloodstream infections from all the lines they put. But they just can't imagine why anyone has to talk to them about hand washing. They say, no, hand washing. I'm an ICU nurse, I'm an intensivist, I do all these complex things. And you say, I need to attend a training on hand washing. So you need to continually have that buy-in. One other fact of life for us, I don't know what the experience is elsewhere, is that the people that are interested and do the day-to-day work, quality assurance, quality improvement, are fairly middle-level staff. Some of them are management staff. Yes, there are a few executive staff so that we have the whole organizational buy-in. But the people that do the enforcement work, the people that collect the data, the people that make sure there is compliance with policy are fairly middle-level staff, at least for us. So it's a daily grind to make sure, particularly the consultants, and I apologize for the specialists and consultants that are in-house, but really they just see these people as meddlesome. And it's a continuous work to make sure that, they take ownership and they see these people as helping them to improve outcomes and improve the safety of all those that have come to us for care. The last bit I will mention very quickly is that, yes, at the beginning, we started with we had to separate the person from the process. And if you want to know where your processes are failing, if you want to know where your areas of needed improvement, then people just need to be honest about reporting near misses, reporting adverse events. You simply need to know if you are then going to have a focused improvement plan in place. And to get people to report all these near misses, then they need to know that it is for improvement purposes, as Tabitha did say, and not going to be punitive. And for that, you need to separate the person who has made the error from the process that allowed that error to happen. And at the beginning, we had a no blame culture. And I could remember that by the time we were preparing for the third accreditation, that's about 2017, executive management was saying, look, we need to move away from this no blame culture to a fair blame culture. People simply need to be responsible. And yes, we won't penalize you if indeed it's the process that is a weakness in that. But people also need to take ownership, and there has to be a fair blame culture. And haven't heard how many 2010 to 2017, 7 years of saying no blame. And now that there is a new prophet in town and he's preaching the gospel of fair blame, you can imagine that he's not altogether very popular. But that is where we are now. And I think the bits that we are currently tackling is to make sure that the people who, as new members of staff, join, they are quickly onboarded onto the quality journey as quickly as possible, so that as they are being onboarded into their area of work, they are also embedded and onboarded into the whole quality setup. Because it's only when you successfully do that that you can say you have a culture of quality. And for that, I mean, it's a continuous process. Quality goalposts keep changing. What was acceptable last year is not acceptable anymore. So for those that are involved, at least for the leadership, it's a continuous process. And that is what I spend a significant chunk of my time doing these days. Thank you.
Wow, thank you. Thank you very much. Hega, I don't know if you have anything to add on the accreditation and the continuous quality improvement. There are also some questions in the chat, so we'll come to them.
Yes, so I mean, I think that, yeah, accreditation by its character or nature is about continuous improvement. And I think that what it really does is provides the framework in which we can have the continuous improvement. In our scenario, it's accreditation that provided for us the standards by which we were even going to measure the quality of healthcare or the safety, as it were. And then also seeing your operations through the eyes of an independent third party, I think is eye-opening. I mean, it's easy for you to compare yourself with your peers in the country or in your area of jurisdiction and think that, I mean, you are doing fairly well. But when you have to benchmark against international standards and have an independent party review and look and, as it were, lift the hood and see exactly what is in there, I think that it provides a good insight and becomes a challenge for you to want to bridge the gaps that are discovered. And so for me, I believe that accreditation provides a good platform or foundation for continuous improvement. And then the assessment tool for which you can actually measure the quality of care. It gives you opportunity to measure it by numbers, because then it's not even a perception anymore. You can really see that is there any improvement and what are the gaps? And because the standards are preset, you can see the gaps and it challenges you to work towards it. So I believe that it's the foundation and also ties in completely with quality improvement.
Thank you very much. So now let's go to the chat. So I'll read a question and please any of you can answer. It says, how do you maintain a just culture that encourages people to speak up about near misses, etc.? I don't know, any of you can take it. So please, at this time, let's please give some brief responses.
Well, yes, I think I can speak to that. I'm sure the other panelists too. It has to come from leadership. Leadership needs to show that the processes are strong enough and that the processes are there to protect the patient, yes, but to also protect the staff. And yes, at times, because processes are not 100%, at times they have weak areas. Despite the overwhelming and natural tendency to punish when something goes wrong, leadership has to stay true to that culture of saying, before we say that it is the person, we will fix the process. And it takes time. It's not going to happen overnight, but with time, people tend to realize. And in my example, the three areas where it is easiest to show commitment to just culture is in pharmacy, particularly with regards to medication errors. It's in the laboratory when things might have gone wrong, and with the nursing staff. And we specifically went out of the way to make sure that when any drop ball, we will and then announce the fact that this was the weakness in the process that we found, and this is the fix, and then quickly train on that. So leadership has a big role to play.
Thank you. So let me ask, this is the powerful reflections, Tabitha, on the culture change. I can imagine how difficult that was. I heard Sir Donaldson say sometime that one of the features of successful organizations is a strong response to a weak signal of failure. Moving from just reporting adverse events to jumping on near misses represents exactly that. I don't know whether there are any comments, but let me ask this as well. It says, can the panel indicate to what extent the fact of being accredited assisted the facility to manage the impact of COVID? So maybe Tabitha or Hagar, and then I can come back to Dr. Kunle.
Absolutely. Being accredited, I think because your governance structures are in place and being guided by the accreditation process and quality standards that you've been working according to. When it came to the COVID pandemic, the initial stages were obviously that of fear. No one knew what we were dealing with. There was no guidance, no clear instructions what this virus was going to do. Healthcare workers immediately turned to self-preservation as a fear of getting the virus. So it didn't necessarily follow the correct protocols and procedures with regards to your PPE and infection control. So one of the things we picked up immediately as a result of that were, because we were monitoring outcomes, is we had a spike in hospital-acquired infections. We were able to trace back the fact that because healthcare workers were scared, they were putting gloves on inappropriately, gowns, moving between patients without actually changing everything properly, we were able to then start the education process going back again with our cycle of, this is why we have a policy on the wearing of PPE. This is why you wear gloves at certain times when dealing with a patient, you know, and really got back down to the basics. So I think without that governance framework, it would have been much more difficult to implement proper processes and manage the pandemic. So I want to just add on to that, on top of the COVID pandemic and the emergency preparedness of the hospital from the pandemic perspective, as a hospital and as a town, we experienced severe civil unrest right in our city and actually right around the hospital in July this year with the unrest and the looting in KwaZulu-Natal. Because we had our systems in place, not in terms of emergency preparedness, which is part of your accreditation process, it teaches you to always be prepared. Not one of us picked up a file to look up what we needed to do. It was embedded and ingrained in us as a team because we do our mock drills, we practice things. We were physically threatened in the hospital because of the unrest and the looting and the riots. So we had that on top of the third wave was actually on us with COVID as well. And I think had we not been prepared because we hadn't been through the accreditation process, it could have been a lot more disastrous. It wasn't disastrous in terms of patient care, it was disastrous in terms of what was happening in our city. So it definitely helped us with regards to managing the pandemic, but then also managing civil unrest. Thank you.
Wow, thank you. Hagar, if anything, accreditation and COVID, did it help?
Well, I think it did, and I was just trying to switch the question around and asking, did COVID help not so much even accreditation, but the whole quality management process? And I think that COVID made it. We saw the reality or the high price that we had to pay if we didn't, adhere to, these quality processes or quality improvement processes, as it were. I think that if anybody had any doubts, COVID was one scenario. If we were talking about hand washing and hitherto you haven't seen the need, I think that COVID made it right in our face that we didn't have a choice anymore to keep safe and to keep our patients safe. So yes, and I agree completely that without the processes in place and the standards in place, I think would have been more chaotic. COVID has its own unpredictability and we're still dealing with the effects of it. But I think that what we had was, like I said, a framework or a quality management process that helped to contain. So it's not even so much accreditation itself, although that provided the platform or the foundation, but I think that is more of the quality management and risk management processes that accreditation brings to our operations.
So this is to any of you. Have you seen any measurable reduction in medical legal cases occurring in association with your accreditation journey? And then
I think that the dynamics are a lot more and a bit more complex, I think. And yes, whilst yes, a part accreditation in part prepares you and to prevent harm and to protect you. I think that there is also, that debate of how more sophisticated our clients have become and aware of their rights that they have become and what they are willing to pursue. So I think that, yeah, the factors are a bit more complex than just accreditation. But I think that, yes, it goes a long way to at least protect you and to prevent harm.
Okay, who is, yeah, okay, so Dr. Kunle, please add your response. In your response, add fair blame and just culture, whether they are the same, because that came from you during your submission. Thank you.
Okay. Well, if I could just add to what Hagar has said, I
Yes.
don't think there is direct cause and effect between accreditation and reduction in lawsuits. That is difficult to show, certainly. And as she has also said, the populace itself is becoming more aware. But certainly what accreditation does is it makes you more visible, and in the community, in the healthcare industry, it certainly makes you more visible. It gives you a greater name recognition, but it also means that people hold you to higher standards. And what they were probably willing to accept in St. Elsewhere's, in some suburban place, they certainly will not cope with, just because you yourself have announced that you are holding yourself to such high standards. But certainly there is no direct cause and effect. I wouldn't be surprised, however, if in some indirect way, it probably lowers the threshold for people willing to, take you to court. With regards to fair blame and just culture seems to be the formally recognized term for what we will call no blame. And just culture is the culture that says that if things go wrong, it is more likely to be organizational and the processes that are in place rather than the individual. And you should not blame the individual, but identify, find out where the weakness is and fix the process. So just culture seems to be more in keeping with the no blame. But fair blame is saying that you have a responsibility here. And that responsibility is in 2 or 3 ways. One is, as a professional, then certainly there is a responsibility on you to do things to the highest possible standards, benchmarked against best practice. So as a professional, you will be held to best practice. And that best practice is regardless of the process. That is one. Two is, as an owner of the process, then you are also partly, it also behoves on you partly to identify weaknesses in the process and to fix those weaknesses before the Swiss cheese holes will line up and a harm or potential harm will happen. And I think thirdly is the fact that you also have to be responsible here. So yes, that is the concept behind the fair blame, that if there are weaknesses in the process, as responsible to hold yourself to best practices. And secondly, to take ownership of fixing the process and fixing it before harm occurs. One has to be careful of going down the fair blame road, because if it is not properly communicated, then before you know it, all the gains you have made in the days of just culture will be very, very easily lost. So it's a balancing effort, I dare say.
Thank you. Thank you very much. So we are ending in 10 minutes. Otherwise, I don't know whether our panelists will be gracious to take us to 30 minutes. But this one is asking, how do you make sure each staff reads, understands, and implements the policies and procedures that has been developed? I don't know who is taking that.
I'm happy to take that. So what we did is, every time there's a new policy or there's an update in a policy, we actually work through the policy with our staff and we have a training register. So at shift change, the manager of the unit will introduce the new policy where it's relevant to the department, and they will actually work through the policy as a team. And we keep a record that the staff have read and they understand the policy. So they have an opportunity to question anything with the policy and to also ensure they understand what is required of them. So it's a documented process that we follow, and then we keep those registers as proof that they've been through the policy as well.
Wow, thank you. Please, any addition? Yeah.
Yeah,
yes,
so
add something. Oh yeah, Haga, please go on.
All right, thank you. So I think that, yes, Doctor already touched on it, but what we have done is to weave it into, the entire HR process. So it's part of orientation as a new employee comes on board, and the new employee is more likely to commit to read because they've just come on and they are more eager. Although we've had a few casualties where post-orientation, the staff has resigned and says, this is too much school for me at this stage of my life. So we've had those. And then also we weave it into the performance appraisal system, because then every criteria ends up being somebody's responsibility, as it were. So then we weave it into the job description and the performance appraisal system. It's difficult, I must say, but I think that is about training, and also monitoring, because people only do what is inspected and what you expect. So I think that is how we have tried to go around it.
Wow. Yeah, so Dr. Kunle.
Yes, in addition to what Hage and Tabitha had said, the other thing that we do is, after doing the training, we want you to show evidence that knowledge has been gained and knowledge has been transferred. So we do require our staff to take a test and to pass the test. So, and that then feeds into the appraisal process. So for every training, there is a minimum attendance requirement for the staff. And then we also expect that you will achieve some level of some pass mark. So it is rarely it is not punitive at all. It's one, for them to take it serious and to show that attending the training and acquiring the necessary knowledge is just as important as your day function. And it shouldn't then just be a routine because it's a requirement. You need to take an exam and pass the exam. We have been lucky so far. We haven't had anyone saying this is too much school for me. We make sure that the questions are easy to understand and easy to pass also. So that's encouraging.
Thank you. Now let me ask this, and I know they say in the context of accreditation and responsibilities it creates, how do you manage agency staff? And I'm sure it's the same as locum staff who move from one hospital to another and are seeing different SOPs in every facility.
Maybe, Salom, if I can even add a little bit to that question to make it a lot more complex, because the locum staff or agency staff, you have them coming in at short notice to bridge a gap that you have. And it takes several hours of training for your regular full-time employees. So even for us, the greater challenge is even how to get them to familiarize themselves in the shortest possible time so that they can be used. It's a tough one. So I'd like to hear what my panelists, co-panelists have to say.
Okay, so Tabitha and Dr. Kunle, any insights?
I agree with and concur with Hagar. It is a much more difficult management process. So what we've implemented is we have clinical facilitators for the various agencies we use. There's 3 of them. And we insist that the staff who are going to work in our facility or want to go onto their books to work in our facility actually go through an orientation process first. And part of that includes the clinical facilitator working on the floor with them and going through the policies. It's a challenge though when you are having to bring agency staff in at short notice because you're in the middle of a pandemic and there's so many people off sick. But we still hold the manager of each unit accountable for the staff working in their unit, and we try and buddy up wherever possible. It's not always possible with somebody else, but it is a challenge. I think what's working in our favor will come in the next short while is the implementation in South Africa of the Office and Health Standards compliance, where all healthcare facilities, private and public, will be working through to very similar accreditation levels that we have done with CASASA. So that should standardize care across the different facilities and make it easier for locum staff to move between the hospitals. But it is a difficult one to manage.
Wow. Don't know any insight? Yes.
Oh, I must say that probably we are a bit luckier than most, in the sense that a large chunk of our locum staff, particularly with regards to nursing, are ex-Lagoon Hospital staff. People who have since moved on, either because they've been poached by hospitals starting on the quality journey, or they've moved on for other reasons. We tend to keep a bank of them, and they will be our first port of call when locum staff is needed. Obviously, they are easier to train. They are easier to brush up with regards to changes to policy. But I quite agree that those who are just totally alien to your processes, you really do need to train them before you deploy them. And that is always a bit of an issue. That's always a challenge. One other area where we have a challenge is with regards to the consultant staff, because again, we have a large bank of local consultant staff. And because it was so difficult to get them all onboarded, we gathered them all into a hotel room a few days ago, breakfast and lunch, and trained them on the processes. But that's not something that you can do all the time, because these are people that, again, work for other facilities aside from us, and they have a day job and all. But at times, you really just need to take these drastic measures, because otherwise, and these are people of influence, if the more junior staff see that surgeon A or pediatrician B or gynecologist C is always breaching procedure, then it just makes it that more difficult for you to enforce them. But certainly this category of staff, they pose challenges, certainly, no doubt.
Wow, thank you. So I asked this final question. and I'm sure Dr. Kunle, this will be for you. It says for private hospitals in Nigeria that cannot afford specific specialists for procedures, what's the way forward? What's the way forward as regards that vis-a-vis quality and access to care? I hope the question have been asked.
Well, my understanding is that what happens to smaller hospitals that use one doctor, one consultant grade staff to work across specialties, maybe a family physician that also operates and sees children and all. And the thing is that they can still be trained on processes, and processes don't teach you how to remember cesarean section. They don't. Processes have to do with what are the steps that lead to that actual procedure so that the patient doesn't come to harm. And after the procedure, what are the processes in place for ensuring that he or she is well looked after? So yes, I imagine that in this regard, the skills are already available. It doesn't mean that they are done well, but certainly the basics are in place. There are organizations, since the question was specific to Nigeria, I know that there is a society, I sit on the board of that society. It's called the Society for Quality in Healthcare in Nigeria. And it aims to train doctors, nurses, all healthcare workers with regards to processes and processes of care and all these things that will become necessary for an accreditation journey. And this kind of professional that this question has then referred to will certainly benefit from that kind of training, because the skills for doing the procedure is already in place, but the processes that keep the patient safe, the fact that you know how to remove an appendix doesn't mean that the patient can still not come to harm. And it's those processes that keep the patient safe that then needs to be taught. And that needs to be taught to everybody, regardless to whatever medical skills or knowledge that you have. Will be my answer to that question.
Thank you very much. So, I mean,
maybe if I can just throw in.
Yes, please go ahead.
Just a little, thoughts. I think this platform is wonderful, but I'm saying that can we move this conversation further, where quality is, incorporated into the training and our institutions of training, in the basic training of the healthcare professional. Because then the analogy of that farmer who wanted to ensure, a bumper harvest or a good harvest all year through provides authentic seed to neighboring farms because cross-pollination is inevitable. I think we need to look at this, because at the end of the day, the reality is train people, as Dr. Kunle said, they approach, they move on, people leave, you keep training, it's an investment, you keep losing, you bring new people on board, you have a challenge of, sustaining what has begun. And I think that as a continent or as a nation, we need to look at, equipping every professional with some basic quality skills that ensures safety of care, in our institutions. Otherwise, it feels a bit sometimes like a losing battle.
Thank you. So, I was going to ask the panelists to share their closing or concluding remarks. And if there are
I think I've just done mine.
No problem. If there are any concluding remarks from the panelists, I'm sure we are happy to take them. Maybe Hagar has done. Yes, so Dr. We go to Lagoon, then we come to.
Yes, there is a colleague of mine, a clinician, but now spends a lot of time in the patient quality and healthcare space, who says that and provides evidence that shows that healthcare on its own, hospitals could be a more dangerous place than a nuclear power plant. And hospitals could be, the chances of coming to harm in a hospital is higher than of having a plane crash. And I think those are the kind of statements that bring to bear the enormous responsibility, people in healthcare, and not just doctors now, everybody in healthcare, the responsibility that is placed on us to make sure that those who have walked through our doors seeking care don't come to harm. I mean, and it's just something we have to remember every day, that if not managed, a hospital could be a pretty dangerous place. Thank you.
Thank you. Thank you very much. Tabitha, please, your last words.
Thank you, Ilham. I think for all of us working in the healthcare industry, our priority should always be the patient and the safety of our patients. And we should never accept that what we're doing today is a standard that's high enough. Healthcare should always be striving for a much higher standard and continuously improving. It needs to be embedded and ingrained in all of us, and it should be our way of life. Because at the end of the day, it could be one of us that's lying in that bed needing care, or it could be one of our family members. And for me, it's always, what would I want if I was the patient? What would I expect? And the Hippocratic Oath is first, do no harm. And we need to make sure that we enforce that and instill that in all our healthcare workers across the board, is that it's about the patient and we need to protect them at all costs and focus on quality improvement. Thank you.
Thank you very much. So I don't know whether Jackie is on. When we started, we did a brief. So this program was put together by Africa Society for Quality. This is a Baden association, a Baden group, a Baden society made up of 4 institutions: Acquire in Kenya, Nairobi, and Ruth Bell has spoken briefly about Acquire. There is also the Africa Institute for Healthcare Quality, Safety, and Accreditation. Gilbert was on by his, I can't see him. And then there is COSASA. I will give Jackie a chance to say something briefly. And then there is Patient Safety Africa, led by Sonny. I don't know whether Sonny is on. The objective for this group is simple. One is to spotlight and publicize quality and patient safety efforts and best practices on the continent, with a focus on frontline healthcare. I mean, and it's very amazing to see that on the continent, we have a JCI accredited facility, we have COSASA accredited facilities, and other accredited facilities who are working to improve patient safety and quality. So to spotlight and publicize some of these efforts, to facilitate research and evidence-based practices to improve quality healthcare, to facilitate access to knowledge, learning, and networking on the continent to improve quality. And I'm seeing some requests about some of the institutions wanting to learn from our panelists. And please be expecting emails from me of introductions of facilities that would want to benchmark, that would want to learn from you and your experiences as far as your journey is concerned. So please, when you get those emails, I mean, they are friendly emails and friendly requests. And I know you are going to oblige and mentor these facilities. And the final objective for the group is to engage stakeholders, agencies, and authorities to facilitate standardization and improved healthcare on the continent. So, I mean, as we grow as a group, all of you are welcome. Let us light the torch on the continent as far as improved care outcomes is concerned. I give the last word to Jackie, since I can't see Gilbert on. So Jackie, over.
Thanks very much, Elam, and thank you very much to the 3 panelists. They were really excellent presentations and discussion, and I think you raised some hugely important points. And I was very encouraged by your closing remarks, all 3 of you, where I think you really touched on the heart of the matter, that it's about the patients, and everything we need to do is about patients. And I think what COVID has emphasized for us is it's about patients and staff, because we equally have to look after our staff if we're going to make sure we look after patients. So well done to all of you, and Elam's given you an insight into how we're moving forward with the African Society. And I think it's critical that we start doing things from within Africa. We have got so much talent on this continent, but we have so many challenges. And I think if we can share between the countries and each other and be proud of the sharing and use the evidence that's there and use the skills that are there, we can make a big difference. And I will repeat myself, some of you may have heard me say this before, where I've heard people tell me that the accreditation standards are too high for Africa. And I get very angry because that implies that Africa deserves lower standards. And I don't believe that. It may take us a little while to get there for everybody, but we should aim for the very best for every single person on this continent. Thank you. Thanks, Elam. Back to you.
Thank you very much, Jackie. And Ajibike, thank you very much for the correction that there are 3 JCI accredited hospitals in Sub-Saharan Africa. I don't know whether this is my Dr. Ajibike. And is that my doctor?
It is your very own Dr. Ajibike, yes.
Yes, it is.
Oh, okay. So
Good evening, everyone.
Yes, okay. So greetings. Any insight from you? I said Jackie was the last word, but maybe you will be the last word.
Well, thank you for giving me the opportunity to be in on this. I got in a little late, and I'm sure that the panelists have been great. You know, they've shared a lot. But the Hagar's last remark, or last but one remark, is something that I think we need to take back and begin to think about. How do we spread the virus of quality and safety in such a way that it's even more infectious than COVID, right? How do we make sure that everybody, every healthcare professional understands that we have no choice, you know, beginning from the fact that we all swore to do no harm, right? But healthcare is inherently harmful. So how do we make sure that we are preventing this? How do we ensure that people understand how to deliver the best quality to the patients? Because as Jackie said, every human being in Africa deserves to get the best quality care. Why should we not be able to deliver that? So I think there's a challenge that's been thrown out to all of us. How do we train our staff to fully understand this and be able to deliver that care? For me, that's the next level of the challenge. And we really all need to think about how to get that done. So, well, over to all of us. Thank you.
Great, thank you. Thank you very much. Extremely grateful to Dr. Kunle, Tabitha, and Hagar.
Hello?
Yes, hello. Hello. Okay, so we are extremely grateful to our panelists. I mean, the insight
yes,
you have.
I can hear you. Sorry.
Yeah, so Dr. Ajibike, I think we are grateful for your inputs and the insight you shared. Thank you very much. So we are wrapping up. Good. So extremely grateful to our panelists for making the time and the insight you have shared. Very grateful. And as I have said, please be expecting friendly emails and friendly introductions from me as far as some of our colleagues online are concerned, because they would like to be supported in their various journeys as far as their accreditation journeys are concerned. So extremely grateful. Thank you. And we hope that we are all going to imbibe the learning and then inform us as far as our next steps and our improvement efforts in our various facilities are concerned. Jackie has said the closing remarks already, so I would not add any to it. So thank you all very much, and let's continue to be safe, and let's continue to do our best as far as our efforts in improving outcomes in our respective facilities and countries are concerned. Thank you, and over. Bye.
Thank you,
Yeah.
Thank you. Bye, everyone.
Thank you all.
Bye.
Bye.